Thank you for the introduction. Before starting my presentation, I would like to thank Alex and the Talks India class coordinator for organizing the sessions for the DABT exam. It's a wonderful opportunity to share knowledge on this platform alongside some Indian leading toxicologists. So today I will be presenting the chapter 12 from the Castrate and Doll book. This chapter is titled as Toxic Response of the Immune System. To make this session comprehensive, I have not only covered the key concept from the chapter 12, but also reviewed the chapter 8 of the MCQ question book, which focus on the immunotoxicology related questions. So this helped me structure the presentation in a way that address both the theoretical aspect and the applied understanding needed for the exam preparation. So first begin with let's understand what is immunotoxicology is. So it is the study of the adverse effect of chemicals on the immune system. The immune system plays a vital role in defending the body against infection, disease and abnormal cell like cancer. However, exposure to the certain chemical referred to as immunotoxicant can disrupt the normal function of the immune system. These chemicals can come from the environment, the pharmaceuticals or the occupational settings, that is the workplace. So depending upon the nature of the toxicant and the exposure, the immune response can be altered in three major ways. So the first is it may overreact, leading to the hypersensitivity like allergies, or it may underreact, resulting in the immunosuppression, which if the immune system is suppressed, it will increase the susceptibility to the infection or the cancer, or it may mistakenly target the body own cell, leading to the autoimmunity. So understanding these immune system disruption is critical for the public health, drug development, regulatory safety assessment and the environmental protection. So now let me walk you through the key historical milestone in the field of immunotoxicity. So which is over the decades. Understanding these timeline help us how our knowledge of the chemical effect on the immune system has evolved. So in 1950, the scientists performed the thymectomy, the surgical removal of the thymus gland in rodents. They observed impaired immune function in these animals, which highlighted that thymus plays a critical role in T cell development and immune regulation. In the year 1960, the witnessed the discovery of the immunosuppressive drug like azathioprine, which this breakthrough revolutionized the transplant medicine, demonstrate that chemical could intentionally modulate the immune response to allow successful organ transplant. In the year 1970, the Sevesto disaster in Italy was happened due to the high level of dioxin, a highly toxic environmental chemical. This incident established a strong link between the environmental toxicant exposure and the immune system effect, underscoring the birth of environmental immunotoxicology. Now, coming on to the 1980s, there is a significant progress happened in the laboratory method. So, with the development of both in vitro as well as the in vivo immunoassay, this tool enhanced our ability to detect, quantify, and study immunotoxic effect more precisely. And the year 1990, the research shift towards the cytokine, the signaling protein that regulate the immune system. Researchers have found that cytokine dysregulation could contribute to autoimmune disease and chronic inflammatory disorders. In the year 2000, the nanotechnology in the medicine and the industry grew the immunotoxic potential of the nanoparticles also. So together, these milestones from organ function studies to the environmental disasters and technological innovation have shaped our current understanding of how chemical interacts with the immune system. So now the another important part is the regulatory consideration in the immunotoxicology. So the key regulatory bodies are US EPA, that is Environmental Protection Agency, the OECD, that is Organization of Economic Cooperation and Development, and the US FDA, that is the Food and Drug Administration, have established the specific guideline for the immunotoxicology testing. So these guidelines, the importance of these guidelines is these guidelines mandate that pharmaceutical, industrial chemical and the environmental agent can undergo a thorough evaluation of potential adverse effect on the immune system. So the standard immunotoxicity testing, it's involved hematology, and CBC, that is the complete blood count. So to detect any changes in the immune cell population such as white blood cells, lymphocytes, and neutrophils. The second is immunophenotyping, which is done via flow cytometry. In this, they quantify various immune cell subsets such as the T cell, B cell, and NK cell. And the third is the functional assay. These include the T cell proliferation assay, natural killer cell activity assay, and cytokine profiling to evaluate immune cell functionality and responsiveness. Tissues such as spleen, thymus, lymph nodes are examined microscopically to detect the structural and degenerative changes caused by the toxicant. The critical part of this immunotoxicity assessment is to determine the NOAEL and LOAEL, that is the no observed adverse effect level and lowest observed adverse effect level. So for the pharmaceutical, specifically the ICHS-8 guideline issued by the International Council for Harmonization serve as the primary regulatory framework for immunotoxicity testing. So what this guideline tells is all new drug candidate must be evaluated for immunotoxic potential as a part of standard toxicity. If any concern arises either from these drugs or the mechanism of action of these drugs, additionally more detailed immunotoxicity testing is required. And the commonly used positive control in these studies cyclosporin A well characterized immunosuppressive agent. So now we have explored the fundamentals of immunity and understand why it is essential for maintaining our health. So immunity refers to the body defense system against harmful invaders such as bacteria, virus, parasite, and other pathogen. It is a highly coordinated and complex network of cell, tissue, organ, and signaling molecules. Signaling molecules, basically the cytokine, that work together to protect the body from infection and disease. A well-functioning immune system not only fight against the infection but also plays a key role in eliminating the cancer cell, facilitating the wound healing and the tissue repair, and maintaining the overall physical balance, that is the homeostasis. So understanding how immunity works is the function of recognizing how toxicant can interfere with it, which is the core concern of immunotoxicology. So now we have understood how the immune system is. Let's take a closer look at the main components of the immune system. So the first is the white blood cells, which is called as the leukocytes. These are the frontline soldiers of the immune system. They patrol the body, identify the pathogen, and launch the targeted response to eliminate infection. The second is the bone marrow, the origin site for all blood and immune cells, including the white blood cells. It continually produces and releases new immune cells to maintain immune readiness. And third is thymus, located behind the sternum. Thymus is essentially for the maturation of T cells, which are the key player in the adaptive immune response. I'll come to this adaptive immune response in my later slides. Then the lymphatic system. So this is the network of the vessel and lymph node act as a filtration and transport unit. It helps remove pathogen and waste and also serve as a site of immune cell activation and proliferation. And the last is the microbiome. So the microbiome is a physical barrier that also harbors a vast community of beneficial microbes like gut microbia. Together, they contribute significantly to the immune modulation and protection. All of these components, either the white blood cells, bone marrow, thymus, lymphatic system, and microbiome, works in a harmony to provide both innate and adaptive immunity, which is like a rapid response against the invader and long-term protection through the memory. This we will discuss in detail in my upcoming slide. So having understood about the key component of the immune system, now explore the type of the immunity. So immunity are of basically of two type, innate and adaptive. There is a third also there, which is a passive immunity. So in this presentation, we are going to discuss in detail about innate and adaptive immunity. So innate immunity is the first line of defense. It is always active and it is a physical barrier such as the skin, mucous membrane, stomach juice, and this contains the cell like macrophages, neutrophils, and the dendritic cell. The only limitation of the innate immunity is it does not have the memory. So if it responds the same way if the repeated exposure to the same pathogen. While on the other hand, the adaptive immunity. So adaptive immunity is highly specific and developed over the time, usually after exposure to the particular pathogen. It involves the T and B cells and that recognize and eliminate the specific antigen. The hallmark of the adaptive immunity is the memory cells. Like if the infection is happened and the antibody has been produced against that, then this will form the memory cell. And if the same antigen attack again, then the response will be faster and stronger. So this is the function of the memory cell. So as we can see that lymphocyte T and B cells are the part of the adaptive immunity, while the innate immunity consists basically of the neutrophil, phagocyte and macrophages. There are two types of the immunities there, humoral and cell mediated. So humoral immunity is basically the antibody mediated that require the B cells, basically the B cells and the complement system. So point to be noted here, although the complement system is made up of the protein and it is a part of the innate immunity, but it is also considered to be the humoral immunity because it enhances the action of antibodies. And the other is the cell mediated immunity. So cell mediated immunity is driven primarily by the T cells, and T cells are divided into the two subtypes, that is the CD4 positive helper T cell and CD8 positive cytotoxic T cells. We'll discuss in detail in the upcoming slide about these T cell subtypes, and even the CD4 positive helper T cells have a subtype that also we will discuss in detail. So other key players are the antigen presenting cells. So there are three types of antigen presenting cells. One is the dendritic cell, the other is the macrophages, and third is the B cell itself. And cellular mediated immunity is effective against the intracellular pathogen like virus and some bacteria. So having discussed about the two main types of immunity, innate and adaptive, now let's discuss about the B and T cells, immune guardian actually. So these are the two key lymphocytes that are the central for the adaptive immune system. So B cells are produced and mature in the bone marrow. Their primary role is to produce the antibody which help neutralize pathogen circulating in the blood and lymph. Upon encountering the specific pathogen, how the B cells will kill? B cells will activate it into the plasma cells and the memory cells. So which secrete the large plasma cells secrete the large quantities of the antibody. Memory B cells will persist in the body. If it is encountered with the same pathogen, then the stronger and the faster response will be there. And for the memory cells, which are the basis of vaccines also, because they provide the long-term protection. The T cell. T cells are also produced in bone marrow, but they, as like the B cells, they won't mature in bone marrow. They mature in a thymus, a specialized organ located behind the sternum. T cells are responsible for the cell mediated immunity. B cells are responsible for the humoral immunity. These points need to be remembered. These questions are there in that MCQ question book. And which is like T cell is especially important for fighting against intracellular pathogen like virus and abnormal cancer cells. So T cells are of the two types, as I told, CD4 positive helper T cells. These coordinate with the immune response. So the helper T cell function is they coordinate with the other immune cells, and they also signal to the B cells, cytotoxic T cells and other immune cells for this through the secretion of cytokines. In the upcoming slide, we will see what are the cytokines which are responsible through the CD4 helper T cell and CD8 cytotoxic T cell. These cells directly destroy infected or abnormal cells, including the virus infected and tumor cells. So now, is I am audible? My voice is clear? Somebody can tell me?
Yes, it is.
It's fine. It's fine. Please proceed. It's fine.
Yeah, thank you. Thank you for that. So B and T cells often work in a close coordination. For example, helper T cell assists the B cells in producing the high affinity antibodies and promoting the class switching. So we'll come to this point also. So now as we have understood about the role of the B and T cell, let's take a closer look at where they come from and how they develop. So both B and T cells originate from the hematopoietic stem cells. This figure was discussed by Dr. Jaideep Mistry yesterday in his presentation. So from the hematopoietic stem cells, the myeloid progenitor and the common lymphoid progenitors are there. Myeloid progenitor will give rise to the megakaryocyte, which ultimately becomes platelet. Erythroblast will give rise to the red blood cells, and myeloblast with the granulocyte, that is a monocyte, neutrophil, basophil, and eosinophil. While the B and T cells are derived from the common lymphoid progenitor, and these hematopoietic stem cells are multipotent. So B cells mature within the bone marrow itself, as I discussed in my previous slides. During the maturation process, the most critical part which has happened is each B cells undergo gene rearrangement to develop a unique antigen receptor, which is called as the B cell receptor. Only those B cells that successfully recognize the non-self antigen without reacting to the self antigen are allowed to fully mature and exit from the bone marrow, because if it is reactive against the self antigen, they can cause the autoimmunity. So that is the reason this is the checkpoint for the B cells. And T cells originate in the bone marrow, but they migrate to the thymus for the maturation. And once mature, this both B and T cell enter the bloodstream and migrate to the secondary lymphoid organ, such as the lymph gland, spleen, and MALT. MALT stands for mucosa associated lymphoid tissue. They remain in a surveillance state in these secondary lymphoid organs and ready to be activated upon encountering their specific antigen. So now, as we have covered the origin and development of T cell, let's take a closer look at how T cell differentiate into the specialized subset after they leave the thymus, and how this differentiation shape their immune system. So first is the thymic selection. So positive selection in the thymus ensure T cell can recognize self MSC molecule as what is happening with the B cells through the gene rearrangement. And the negative selection eliminates T cell that react strongly to self antigen, promoting the self tolerance and preventing the autoimmunity. Now the two main type of the T cell subset, that is the CD4 positive and CD8 positive. CD4 is the helper T cell, CD8 positive is the cytotoxic T cell. When I am talking about CD, CD stands for the cluster of differentiation. So cluster of differentiation means the CD markers are exactly like a jersey with a number, so you can identify that particular immune cells. Okay, this is like CD4 positive, this is helper T cell. CD3 expressed in the common C cell. For B cell, it is CD31. For macrophages, CD60. So in this way, they are different CD markers are there to the different immune cells through which they can be recognized. When we do the FACS or the immunophenotype, we can sort out the cells based on the CD markers. So CD4 helper cells differentiate into the specialized subset of the cells, that is the Th1, Th2, Th17, and the Treg cells. So the function is for the Th1 is they are defend against the intracellular bacteria and virus. Th2 respond to the helminth and involved in the allergic responses. Th17 is activated during the inflammation process, and Treg cells are the suppressor of the immune system. It prevents the autoimmunity, and these are the cytokines which are related with the subset of the CD4 helper T lymphocytes. So Th1 is secreted by the IL-2 cytokine and Th2 through the IL-4 cytokine. And these are the further transcription factor which are related to that TBET for Th1, GATA3 for Th2, and FOXP3. FOXP3 is actually, if you read about the CD markers, FOXP3 will also come in that, as it is a regulator for the Treg cells. But this is not a CD marker, this is a protein actually. So now let's discuss about the specialized tissue macrophages. So these macrophages play a critical role in both innate and adaptive immunity. They are the bridge for the innate and the adaptive immunity. They are the white blood cells which are derived from the monocytes. They act as a body professional cleanup crew because they are capable of engulfing and digesting the pathogen, dead cells, and debris through a process called phagocytosis. The name phagocytosis was given by a scientist called Ali Meshnikov, and there are the tissue resident macrophages, means they found in the different part of the body and they adapt uniquely to those tissue and perform the function according to that tissue. So some of the examples are, for the liver it is the Kupffer cells, for the lung it is the alveolar macrophages, for the skin it is Langerhans cells, for brain it is microglia, for bone it is osteoclast, for kidney it is renal macrophages, and for joint it is synovial macrophages. So these all are resident to their specific organ and perform the function according to that organ. So they are actually fine tuned to the organ specific immune and maintenance role. So macrophages are also classified as the APC. As I told in my earlier slide, there are three APCs: macrophages, dendritic cell, and the B cells. So they are the first responder for the infection and the injury. They perform the phagocytosis, and then they also present those to the T cells. So they present the phagocytosis, do the phagocytosis of the antigen, and then present the antigen fragment to the T cell, thereby initiating the adaptive immune system. So there is a bridge that it is also causing the phagocytosis and presenting the antigen fragment to the adaptive immune system like the T cells, and then T cells activate the B cells, and adaptive immune system also come in the picture. So they also release the cytokine and the chemokine, recruiting and activating the other immune cells. And there are two types of macrophages depending upon their polarization. So one is M1 macrophages, the other is M2 macrophages. M1 macrophages is pro-inflammatory and anti-tumor, while M2 macrophages is anti-inflammatory and it is tumor promoting. So their balance is very important. If in cancer cell, mostly they express the M2 macrophages because it helps in promoting the tumor. So now, as we have discussed the macrophages and their role as antigen presenting cell, it is important to understand how antigen are presented to the T cells and how antibody function through the Fc fragment crystallization region to eliminate the pathogen. So what happens when the pathogen enters the body? This is APC, like macrophages and dendritic cell, they cause the phagocytosis. Then the pathogens will present to the, these fragments were present to the T cell known through the MSC. MSC is major histocompatibility complex. So MSC class 1 present to the CD8, that is a cytotoxic T cell, and MSC class 2 present to the CD4 positive helper T cell. So this presentation allow the T cell to see that this is a foreign pathogen and they become activated. The activation of T cell is a critical step in launching the adaptive immunity. Once the T cell got activated, they activate the B cells, and once the B cells got activated, they through the plasma cells, once they got activated, they are converted to plasma cells and produce lot of antibodies, and each antibody has a two fragments. First is the Fab region, which is variable, and the other region is the FC region, that is the fragment crystallization region. So how this fragment crystallization region work? So first it facilitates the phagocytosis, right? Like FC region is bind to the macrophages and neutrophil, enhancing their opsonization process, which will ultimately lead to the phagocytosis. And they also mediate a cell mediated killing by binding with the NK cells and triggers the antibody dependent cellular cytotoxicity, that is ADCC, leading to the destruction of the infected or cancerous cell. And third is the complement activation, like the FC region initiate the classical pathway of the complement system and causes the lysis through the membrane attack complex. So the complement system, there are the different like around 8 complement proteins, C5a, C6a, they form the membrane attack complex and do the lysis of this pathogen. So this is the function of the FC region of the antibody. So now that we have understood the antigen presentation and how antibodies eliminate the pathogen via their FC region, let's focus on another key immune warrior, that is the cytotoxic T lymphocyte, also called as the CD8 positive. So they are the specialized type of the cells which are like directly kill the and destroy the pathogen or the abnormal cell. So they are basically, once the antigen presented via the MSC, the CD8 cell encounter its specific antigen and an infected cell, it get activated, transforming from the naive to an effector cytotoxic T lymphocyte. So what is the mechanism of killing of this cytotoxic T lymphocyte? Is either through the perforin and the granzyme pathway, perforins which form the pores in the membrane of the target cell, and enzymes enter through that pole and trigger the apoptosis. And the other way is the cytokine secretion. They secrete the cytokine like TNF alpha and interferon gamma, and these cytokine recruit and activated the macrophages. Then the third part is FAS and FSL pathway. So they can trigger the this apoptotic intrinsic apoptotic pathway through the caspase 3 enzyme. So these are essential immune surveillance against the tumor, because recognizing the abnormal antigen and which is expressing on the cancer cells, so they directly destroy it. So that is the reason where they are called as the cytotoxic T cell. So they also do one thing: when they form, like when they eliminate the pathogen, then most of the T cells, cytotoxic T cells, will undergo apoptosis to maintain the self tolerance, while some of the cytotoxic T cells maintains the memory. So if the same pathogen will encounter again, they will have a fast and the stronger response to them. So now that we have explored the role of T cell, B cell, cytotoxic T cells and antigen presentation, let's understand how the T cells kinetics is there. The dynamic process occurs in the phases that are the activation phase, clonal expansion, contraction, and memory formation. So in the activation phase, as soon as the immune response begins against the pathogen, the APC such as macrophages and dendritic cell process the pathogen and present the antigen fragment on the MSC. Naive T cell recognize this through the T cell receptor, which leads to their activation. And once this got activated, then the clonal phase will start. T cell rapidly proliferate in a process known as the clonal expansion, and this will create large pool of CD8 positive cytotoxic T cell and CD4 positive helper T cell, which are also responsible for activating the B cell and antibody production. They also stimulate the macrophages and release cytokine to amplify more immune function. The third is the effector phase. This is the expanded T cell now carry out their effector roles actually. CD8 positive T cell destroy infected and cancerous cell, and CD4 positive, they are like orchestrate the broader immune response to the ensure the pathogen clearance, because they will activate the other T cell, they will secrete the cytokine, they will direct the macrophages, and they will signal through the cytokine to the B cells also to produce more antibody to clear the pathogen. And then comes the contraction phase. So after the infection is eliminated, most of the activated T cell die through apoptosis. This contraction phase is essential for preventing excessive immunity and avoiding the tissue damage. Then the memory phase will be there. A small subset of the T cells serve as a memory cell, and it will, like, these are the long lived memory cell, which is the basis for the vaccination also. And as I told in my earlier slide also, they are faster, stronger, and more efficient response. So the T cell is, the basic summary is, T cell is tightly regulated with activation, rapid clonal expansion, effector function, contraction, and formation of the memory, because this kinetic ensures that both effective immune defense and immune system regulation protect the body without causing the harm or without causing the self damage. So these are the factors which are affecting the immunity. So like stress impact, the chronic stress, which is like chronic stress will elevate the hormone like cortisol, a stress hormone that suppress the immune cells activity. So this is also related to the immune suppression. Now the sleep, the adequate sleep is required, because sleep depreciation will lead to the reduction and production of the immune cells such as the T cells and the NK cells. The right nutrition is required, like vitamin A, C, D, and E. Mineral like zinc and iron, if there is deficiency is there, it will impair the immune cell function, antibody production, and the cytokine signaling. Then the aging, that is the immunosenescence. With the age, the function naturally, like immune function will naturally declines. The process of this is called as the immunosenescence. Older adults have fewer T cells, reduced vaccine response, and greater susceptibility to the infection and the chronic disease. And the last, the important one is the xenobiotic. Xenobiotic are the foreign chemical substance that is not naturally produced by the body. They can be comes from environmental pollutant, industrial chemicals, or pharmaceuticals. Some xenobiotics act as immunotoxin, suppressing the immune response or triggering the inappropriate immune activation. There is a core focus of immunotoxicology actually. As such, exposure can lead to the immunosuppression, autoimmunity, and hypersensitivity, which is the part of the immunotoxicology. Now, these are the factors that will modify the immune system. These are the genetic factors which are inherited, like the skin disease and the life and the stage. So I'll go one by one on this. So the genetic factors is like they are genetic factors make the foundation for both innate and adaptive immunity. So once the genetic variation can cause the susceptible to the infection also, they can influence the risk of the autoimmune disease, and they can affect the vaccine responsiveness also. So examples are like certain HLA gene variants are associated with a higher risk of the autoimmune disease such as the type 1 diabetes and rheumatoid arthritis. So the second is the inherited immunodeficiencies. So some individual born with a immunodeficiency disorders, which is impairs B cell, T cell, phagocytic cells. So they are like the consequences. They get the frequent infection. They poorly response to the vaccine and the increased risk of the immune dysregulation also. The life stage and the age. So infant immune system is immature. They rely mostly on the maternal antibodies. Elderly experience the immunosenescence, a gradual decline in the immune function, and the age related changes is there is higher vulnerability to the infections, slow wound healing, and reduced vaccine efficacy. And then the sex and hormones. So estrogen, that is the female sex hormone, tend to enhance the immune function, while the androgen, testosterone, male hormone, often suppress the immune system. So that is the reason why there is a higher rate of autoimmune disorders in the females. Now, having discussed about the host factors, now let us discuss about the hypersensitivity. So hypersensitivity is when the immune system overreacts. So hypersensitivity can be classified into the four major types, that is the type 1 to type 4. So we'll go one by one with that. So type 1 hypersensitivity is the immediate hypersensitivity. This is occur within the minute after the exposure to the allergen. It involves IgE antibodies. This is the point need to be remembered, that it involves IgE antibody which bind to the mast cell and trigger the release of histamine and other inflammatory chemicals. So the examples are the hay fever, allergic asthma, and the anaphylaxis. The type 2 is the cytotoxic hypersensitivity. It can take a hour or a day. This is regulated through IgG or IgM antibodies which bind to the antigen on the surface of the cell, leading to their destruction via the complement system or immune system. So the example are the autoimmune hemolytic anemia, good pasture syndrome, and transfusion reactions. So type 3 is the immune complex mediated hypersensitivity. This also developed several hours today. This is mediated by the antigen antibody complex, and the examples are the serum sickness, SLE, that is the systemic lupus erythematosus, and the post streptococcal glomerulonephritis. And the type 4 is the delayed type of hypersensitivity that appears 24 to 72 hours after the exposure, and this is mediated by the T cell. This is very important. This is mediated by the T cell, not the antibodies. Means B cell won't play a role in this. So T cell release the cytokine that recruit immune cell, causing the inflammation. The example are the contact dermatitis, tuberculin skin test, that is the Mentoux test, and chronic transplant rejection. So these, so this is the important part. Hypersensitivity type 1 to type 4 to be remembered, and type 1 related with the IgE, type 2 with the IgG and IgM, type 3 with the antigen antibody complex, and type 4 with the T cells. So now next we will cover the, now this slide we will review the summary table actually that outlines how various chemical classes known as the immunotoxin affect the immune system. So type 1, that is the immediate immune suppression. These agents reduce the T cell activity and cause thymic atrophy, which weakens body ability to fight the infection. Common immune consequences is the general immune suppression in this case. So dioxin, as I discussed in my historical slide, which is related to the Seveso disaster in Italy, dioxin are also the potent immunosuppressant. They cause profound thymic shrinkage and decrease antibody production, leading to a significantly weaker immune response. Then the metal like lead and mercury. Mercury triggers the SLE and lead impairs the macrophages function. Then the pesticide. This is also causing the reduced NK cell activity and altered cytokine production. And then the isocyanates, known for inducing the hypersensitivity type 1 and type 4. Then the drugs like penicillin and sulfonamides, they also cause type 1 and type 4 hypersensitivity. Then the halothane anesthetic agent. So these are specifically immune, they cause specifically immune mediated hepatitis, where the body own immune cells attack the liver post exposure. Then the checkpoint inhibitor, they can cause the immune related adverse events. And the examples are the colitis, dermatitis, thyroiditis, and pneumonitis. And then the mycotoxin. So mycotoxin is like it causes the immune suppression by reducing the cytokine production. So they basically reduce the signaling pathway of the immune system. So if the signaling pathway is reduced, the communication won't happen between the immune cells. If the communication won't happen, then the immune suppression will occur. So now let me walk you through the toxicant effect of the biological system, starting at the cellular level and progressing to the organism level. This cascade will illustrate how molecular event can lead to the serious outcome if left unchecked. So the cellular response. So oxidative stress, an imbalance between the generation of free radicals and the body ability to neutralize them. This led to the DNA and protein damage, mitochondrial disrupt ATP production, affecting the energy and triggering the cellular dysfunction. Inflammation, this often oriented as a protective immune response to the cellular energy, but when becomes chronic, can cause the tissue damage and the disease. Then the immunotoxicity, the immune system may become overactive, leading to the hypersensitivity, or suppressed, leading to the increase in the chance of the infection. Then the altered gene expression. Changes in the gene regulation can disturb the normal function, signaling or growth, potentially predisposing the cells to the cancer or degeneration. So the cell death is like damaging mechanism often caused through the apoptosis or the necrosis. So when the cellular damage is done, then it will come to the it escalate into the systemic effect, and which will lead to the organism level damage. So this will be related to the reproductive toxicity, which is infertility, hormone disruption, then the development toxicity, birth defect and neurodevelopmental delays, and then the chronic inflammatory disease, that is the arthritis and asthma. So by catching the early cellular events like oxidative stress and gene dysregulation, we can better predict, prevent, and manage the toxicological outcomes before they become clinically serious. So now let's discuss about the immunosuppression, that is the weakened defense, where the immune system ability to fight the infection got decreased. So they become less efficient in with the immune system become less efficient, they will not be eliminate infection, cancerous growth, or the foreign pathogen. So the cause will be, as I discussed, the host factors also. This will be genetic cause, diseases like HIV, AIDS, and certain cancers like lymphoma and leukemia, medical treatment like chemotherapy and radiation therapy, which was given as the first line treatment for the cancer patient, and the environmental exposure, that is the immunotoxic chemical in the workplace or the polluted environment. So in medicine and immunotoxicology, we often either enhance or suppress the immune system. So these are opposite but equally important and the critical approach to manage the immune response effectively. So immune enhancement is to boost or stimulate the immune system when it is underactive or needs supports, like for the vaccine responses. So flu vaccines, we all know that flu vaccines but works better in the individual with a well functioning immune system, while the checkpoint inhibitor like PD1, CTLA4, PDL1, and others, the T cells, they also help the T cells to kill the cancer cell fast if the immune boosters are given. then the faster recovery from the infections or the illness, and increased immune cell production also is there. Now the immune suppression, so deliberately reducing or weakening the immune response to prevent damage from an overactive or misdirected immune system. This basically like a drug like cyclosporin, tacrolimus, azathioprine stop the immune system from attacking the new organ. This is basically used for the organ transplant where we require to like suppress the immune system so that it won't target the body new organs, right? Now let's see the developmental timeline. This is very important. So immune system development develops and changes throughout the life from the birth to the young adulthood and to the old age. So at birth, newborn are with immature immune system. They both innate and adaptive immunities are underdeveloped. They receive the passive immunity from where? They receive the passive immunity from mothers. So IgG antibody cross the placenta in the third trimester. Breast milk provide IgA antibody that protect the mucosal surface. So due to the limited immune memory and T and B cell diversity, this newborn child are more susceptible to the infection. That is the reason we go for the vaccination. So as they grow, they will develop the innate and the adaptive immunity. So for the childhood and infancy, it is like thymus is at the largest at the birth, highly active during infancy and producing large number of T cells, and these T cells basically at the childhood and the infancy stage are the T Rex cells, because at that time as the immune system is growing, so they promote the self tolerance and prevent the autoimmunity so that it should not harm the body self cells. So as the maternal antibodies wanes up, infant mostly rely on their immune system. So that is the reason why we'll give the vaccination. This will stimulate the adaptive immune response and build the immunologic memory. Then the childhood to young adulthood, as the children grow, their innate and adaptive immune response is strengthened, and young adults experience fewer infections, peak immune efficiency is there, and they strongly respond to the vaccine and pathogen. While the adulthood to the aging, so with aging the thymus reduces the like production of the maturation of the T cells and the production in the bone marrow of the T cells. All these things will be reduces. So that is the reason why older adults face respiratory infection, cancer, and weaker vaccine efficacy. Now let's to discuss about the tumor immune surveillance and the immunostimulation. So this is like the two critical concept in the cancer immunology. So tumor immune surveillance, that is they are the protection against the cancer. So immune system constantly patrol the body, as I discussed when I discussing about the macrophages and the other immune cells of the innate immunity that has the first line of defense. So they constantly patrol the body, they scan the body for any abnormal or the transformed cell that will could become cancer. So CD8 T cell, T lymphocyte, NK cells, once they recognize this tumor associated antigen, destroying them before the tumor can develop. Like patient with an early stage tumors often have the robust immune activity because their immune system is highly activated to encounter the abnormal or the transformed cell, and this high level of they have the high level of T tumor infiltrating lymphocyte, that is a TIL, and TIL is correlate with a better prognosis and suggestive effective immune surveillance actually. Now the immune escape. So immune surveillance also, tumor can involve to evade the immune detection also. So where the antigen loss is there, so cancer cell actually outsmart our immune system because they will lose the antigen, they will do the immune suppression through the cytokine like TGF beta, IL-10, Tregs or MDSCs. Then immune checkpoint expression like molecules like PDL1 inhibit the T cell activity. So anti-PDL1 therapy is required in that cases. So then the dual role of the immune system is the immune system can act as a protector by eliminating the cells, but in some context it may promote the tumor development also. Chronic inflammation and immune suppression with tumor microenvironment. Tumor microenvironment determines whether the immune signal inhibit or promote tumor progression. So a delicate balance between immune surveillance and immune stimulation is very important. So now the emerging issues in the immunotoxicology. So these are the three issues which I put in my slide. So one first is the developmental immunotoxicity. This refers to the immune disruption occur during the prenatal and the postnatal development. Even low level of chemical exposure, very low level of chemical exposure during this sensitive window can cause lasting or permanent immune dysfunction. The second one is the immunotoxicity of the nanomaterial. So nanoparticles are now widely used in the medicine, cosmetics, and the industry. Because of their tiny size, they can cross the different biological barriers. We have biological barriers in our body, they will cross those barriers and directly interact with the immune system. And depending upon their size, shape, surface, charge, and the chemical composition, they may either trigger immune activation, that is like inflammation, or suppress the immune function, impairing our body ability to fight the pathogen. Now, third one is the genetic susceptibility to the immunotoxin. Our genetic makeup influences how we will respond to the environmental exposure. So, like HLA allele or the cytokine genes may increase the risk of hypersensitivity, autoimmunity, and even immune related cancers also. So, immunotoxicology is not just about dose and exposure, but also about timing, material properties, and individual genetic predisposition. So now let us discuss the model and the testing strategies in the immunotoxicology. So the first is the in vivo model, which is have long been used as the gold standard, where they observe changes in the spleen, thymus weight, white blood cell count, and immune response to the infection or the vaccine. And the second is the in vitro assay. So cell-based assay using the human and the animal cells are widely used. These are they assess actually the cytokine production, immune cell activation, antibody response. The examples are the direct peptide reactive assay and human cell line activation test, that is HCLAT. Then the third is the in silico and the genomic approaches. So as the trend was evolving about the transcriptoming and the microRNA profiling allow us to study the gene expression changes in the immune cells, help identify the mechanism of toxicity, reveal molecular signatures. Molecular signatures mean those genes that will cause the immune disturbance, and predict immunotoxic effect without physical testing. And the fourth one I want to discuss, which I have not put in this slide, is the target testing strategy. So regulatory body all follow these steps, where they begin with a general toxicity screens, move to the immune specific assay only if needed. Their tests include like CBC, immunophenotyping, T cell proliferation, cytokine analysis, and immune organ histopathology. So this also I discussed when I was discussing the regulatory guidelines. Now the next is the now let's discuss about the autoimmunity induced by the toxicant. So the autoimmunity, what is autoimmunity actually? When the body or the immune system mistakenly attacks the body own tissues, like they are destroying the self tissue of the body, considering them as a foreign tissue. So like mercury, which is causing the lupus like autoimmunities, and hydralazine and procanamide causing drug induced lupus, and dioxin and PCB generally the autoimmune disease. So now, as we have discussed about the immunity, different aspect, hypersensitivity, antigen antibody reaction, B cell, T cell, and their kinetics and all, let's go through some case study. That is the real world examples. So what has happened in the field of the immunotoxicology? So first is the environmental pollutant induced immune suppression. So pollutants like industrial chemicals, heavy metals, and the persistent organic pollutants like dioxin and PCB. So these are found in air, water, soil, and food. These toxicants damage immune cells directly. They cause the oxidative stress and they disrupt the immune signaling pathway. So what is the impact of this? They weaken the innate and the adaptive immunity. The infection risk will be increases. The vaccine effectiveness will decrease, and it increase the risk for the cancers too. So this highlight that the public health risk posed by the immunotoxin pollutant and stress need regulation, environmental monitoring, and pre-approval immunotoxicity testing for the chemicals. Now let's come to the case 2 study, which is the occupational exposure leading to the allergic disease. So in the US alone, 11 million workers are exposed to the occupational allergen, and up to 25% of the adult onset asthma cases are linked to the work related exposure. Common workplace allergen includes, these are proteins, so like floor, dust, latex, mold, or the metals like nickel and chromium, or the chemicals in the chemical industry like diisocyanate, which is from the what paint is there, paint and the detergents. So what basically they led to their mechanisms, like they will activate the type 1 hypersensitivity. As I told when I was discussing the hypersensitivity, like type 1 is related to the IgE antibody, which will lead to the histamine release and causing the allergy. Its symptoms are the asthma, sneezing, rhinitis, and understanding these mechanisms, especially the IgE mediated response, is essential for early detection, prevention, and protecting the worker health. The third case study is the pharmaceutically induced autoimmunity. So this is like drug induced autoimmunity is a well recognized phenomenon because it's result from the loss of the self tolerant to the self antigen, leading to the autoimmune disease. The common autoimmune disease triggered through this is drug induced lupus like syndrome, autoimmune hemolytic anemia, and pneumonitis. So the common implicated examples are hydralazine, which is causing the lupus-like syndrome, procainamide, lupus and hemolytic anemia, minocycline, autoimmune hepatitis, chlorampanazine, that is SLE-like symptoms, and this is TNF blocker, which may treat or trigger the autoimmunity. So now the case 4 is studied, which is the mercury induced immunity. So mercury exposure has been associated with the immune dysregulation, chronic inflammation, and autoimmune like disease. So what they basically do is local inflammation of the mercury at the exposure site like skin or mucosa. This will lead to the damage, which will release the factor called DAMP. DAMP stands for damage associated molecular pattern. Then the innate immunity, like DAMP stimulate the PRR, that is the pattern recognition receptors, through the toll like receptors. And then adaptive immunity, like the expansion of CD4 cells, all this become compromised. So there are the animal studies to show autoimmune response of the mercury to a various strain, but there is very limited human data present. So mercury induced autoimmunity is a clear example where environmental toxin intersect with the genetic vulnerability, leading to the dysregulated immune system. So I would like to conclude my slide that immune system is our greatest shield, but also our most vulnerable target. So let's continue exploring how science can protect it. And thank you all for your kind attention. Any question, I will love to attend that.